All right, everyone. So we'll go ahead and start it on the last part of this chapter 11, airway management. So this last part kind of talks about like some of the tools in our toolbox beyond nasal cannulas and non-breathers and stuff like that. So let's talk about that. So the patient who is not breathing needs artificial ventilation. Artificial ventilations. This guy, right? With 100% supplemental oxygen. So this would connect to the oxygen tank. I'm not unfolding it. And it would supply this bag with a bunch of air. And so when I squeeze this bag, the air would come from from this bag, right? Like this bag to that bag. So it's similar to an underbreather, and that it is pulling in 100% oxygen because you're pulling the air from this reservoir bag. And so this is artificial ventilations, okay? And so um, in a regular breathing pattern will also require artificial ventilations. So keep in mind, someone with chain Stokes could be breathing 20 times a minute, but if they have chain Stokes, remember that's the apnea, and that's a sped up version of that. But if someone's breathing like that with chain Stokes, then you definitely need to ventilate them with a non breathe, or I'm sorry, with a bag valve mask. Remember, this thing's called a BVM, bag valve mask. So I'm going to use both words interchangeably. Okay. So treatment options for patients in respiratory distress and failure. Sometimes we'll assist their ventilations. Remember, ventilation, air in and out. That's what that means. We'll use this. We'll help them breathe a little bit. Maybe they're getting tired because they're in respiratory failure. Okay. Or we'll give them the CPAP, the continuous positive airway pressure. That's what people sleep with that snore. And we use it therapeutically, in emergency medicine a lot. It works really well, and we're gonna talk about that quite a bit because it's a great tool. It saved a lot of people. So some of this I just got to read it off the slides, which I hate doing, but it's what we got to do. So basically, to use a BVM, a bag mask, and sometimes the book will call it just a bag mask device. Okay, you're gonna place the mask over the patient's nose and mouth. You're gonna squeeze the bag each time the patient's breathing. So this is assisting them, right? So you have to wait for them to breathe, but they're just breathing. They are breathing 16 times a minute. They're just breathing shallow because they're worn out, right? They're in respiratory failure, respiratory stress, right? So you're gonna watch for them when they take a breath in, and you're gonna squeeze the bag. Now this is a one-handed tool. If I see you hold this with two hands, you're going to disappoint me. It's a one-handed tool. You can cause harm, and we do not cause harm, but you can cause harm if you use two hands. Okay, this bag on this one's probably it's well over a liter. It's 2 liters. This says right here it's 2 liters. And how much air did I tell you tidal volume was? Right, it's 500. So you only need like a quarter of this to go in their lungs. It's a one-handed tool. If you firefighter this, as I like to call it, and just like right, it's unnecessary. You're causing harm. So it's just one-handed tool. We'll squeeze of the bag. Okay, and so um, after the initial 5 to 10 breaths, slowly adjust the rate and deliver an appropriate tidal volume, right? You still want to make sure that you're not. If you're assisting someone's ventilations, right? So again, someone's breathing 16 times a minute and you're just helping them out, you may just have to give them a little bitty squeeze just every now and then to help them out, okay? And you're going to adjust the rate and tidal volume to maintain an adequate minute volume, okay? Again, you don't have to squeeze all of this out. In fact, if you do, you're wrong, okay? Even for obese people, they don't have bigger lungs. Okay, so they're truly not big boned. I'm just saying, you don't. For our intents and purposes, it doesn't matter if they're my size, right, 160 pounds, 65 pounds, or if they're 365 pounds. It's still 500 milliliters is the tidal volume for the most part for our intents. Okay, so I I don't think I need to go through the differences in these. I will hit a few of the high points, I guess. So so let me just talk about this is how this will be tested. They'll ask what's the consequence, right, of using positive pressure ventilation. And you're gonna be like, what, Hunter? I thought you said this was called a BVM. I thought you said this was a ventilator. I thought you said this was a bag mask. Yes, it's all of those, but it causes positive pressure ventilation. I am, with a positive pressure, ventilating the patient. And so that's what they're talking about here with positive pressure ventilation. And so what happens is you can overinflate the lungs, and when we overinflate the lungs, they can kind of push on the vena cava, right? That's the big vein that runs through the right side of your chest, center right of your chest. And so when lungs get hyperinflated, it can squeeze, it can kind of push down on that and reduce blood flow back to the heart. It's called reducing preload. And so that's one thing to think about. Okay. Um, let's see. If you overventilate, right, you can increase intrathoracic pressure, of course, but you can also cause gastric distension. So remember the food tube behind the trachea, the esophagus, it's normally collapsed, right, like this. And when you gulp and swallow, it opens up. And then peristalsis, which is rhythmic movement of the muscle, will take it down to your belly. And so if you're just sitting there bagging the shit out of someone like this is wrong, don't do this, right? You're really not going to be forcing all that air into their trachea because you're overventilating them. So what you will end up doing is putting it down their esophagus into their stomach. Well, guess what happens to the stomach? It stretches and stretches until it doesn't stretch no more. And then they regurgitate, they vomit. So be mindful of that. If you overventilate a patient with a bag valve mask, they will vomit, even if they're dead. Okay? It's passive regurgitation is what it's called. So just be aware that there is a consequence of overventilating. So I know sometimes we think like, I'm EMT, I fix things, right? And so we just start ventilating them, thinking some is good, more is better, and it's not the case. Okay, so don't overventilate patients. That's enough of that. Okay, so there is a mouth to so I they're never going to ask you to do mouth to mouth ventilation on the National Registry. Calm down, but there is places that will use a mouth to mask. Okay, and so what you can do is you can take one of these masks, and this one doesn't have it, but there will be a one-way valve attached here to where you'll put this on the patient's face and blow into it. Okay, all this equipment's new, by the way. So when I like get it close to my face and stuff, and so that's something to keep in mind. Okay, um, you want to use a barrier device. So okay, so that's a mouth to mask. Now, if you use mouth to mouth, you should use a barrier device, and it's almost like a piece of plastic. I've seen these in a CPR class. They gave me one, threw it away, but it's like a little. I don't know how to describe it. It's almost like a piece of plastic that has like a one-way valve worked into it, to where like you breathe through it through the patient's mouth, to where because here's the thing which you may not realize is when patients get cardiac when you do CPR they or when patients die they vomit. Okay, they passively regurgitate. Usually there's blood or vomit or spit. There's something in their mouth. Not only that, it's another human's mouth, so it's nasty. So just be aware of that. And so when you do CPR on someone, you have to anticipate that they're going to vomit. Now the mouth to mask ventilation is what I just described. That's preferred. Okay, so yeah, and you can attach this to the oxygen tank at like 15, 25 liters per minute. You want this bag to be filled with oxygen. So when you're using the BVM, they're getting 100% oxygen. And we've talked about this a lot. I love the show and tell. Love showing it to y'all. Um, so that's this, the back valve mask. Uh, most effective when we use it with the supplemental oxygen to where this reservoir bag can be filled. Now, we've talked about the anatomy of this a lot, but the volume of air that you want to deliver is just enough to see visible chest rise. So when I'm using this, real world, right? I'm using this. I'm looking at the patient's chest, and I'm like, oh, okay, that was enough to get chest rise. And for some patients, I might have to go almost all the way, but I never have to use both hands. Okay, it's a one-handed. Well, the bag itself is a one-handed tool. Now, good point. The second bullet point here, this one. If you go like this, and I've seen this, right? It's people get under stress and they do weird stuff. So they go like this. 1, 2, 3, 4, 5. You're gonna force air down the esophagus and not the trachea. And so what happens when we put air in the esophagus, also known as the food tube that's behind the trachea? They vomit. Okay? So be careful of that. So you have to be very conscientious. Even me, right? A fairly experienced provider. I have to be very mindful when I'm using this tool and say 1, 2, 3, 4, 5, breathe. Chest rise and fall. Good. 1, 2, right? And now I might do this internally, right? But I'm actually thinking this, okay? And if I hand this to a less skilled provider, maybe like a state trooper or someone like that. It might be like, I want you to count to 5 and squeeze it this much. Okay, right? And so that's a way that you can work through that as well, by the way. So to use the two-person, so we'll talk about this. Basically, um, if you have two people, this is even better because you can have one person just work on sealing this around the patient's mouth and nose, and then the other person just squeezes the bag. The more skilled provider needs to be with the one holding it over the patient's mouth and nose. That's difficult. Okay? And so the idea is to not just mash this onto a patient's face. It's so you might be thinking like, right, patients like laying flat. Like, oh, I'm just gonna mash this onto their face because that'll make a good seal because you want this to seal so air doesn't escape. The idea is to lift the face into the mask as well, right? So you are pushing it down onto their face, but you're also lifting the mask or the face into the mask and the jaw into the mask as well. Okay, so the one-handed technique is called the C, E, 1, 2, 3, right? So C, E technique. And then if I have two rescuers, which this is almost always how it happens, I'll put both hands over this and I'm pushing down and I'm taking their jaw and lifting it into the mask. So I'm like pushing down and lifting up at the same time. Okay. So if you're alone, you use the EC clamp. I just described that. Here's the C, this. Whoops. Sorry, guys. It's backwards on the camera. C, and then this is the E. The E goes on the jaw. So I'm like lifting the jaw up into the mask. Okay. That's what they're. Oh, I had a picture. What am I doing? C, and then E. Okay. So manually triggered ventilation devices, we actually have these at the hospital district. Actually, they're not manual; they're automatic. But they just shoot out a bunch of oxygen, a set tidal volume of like 500 when it's triggered. Okay. We don't use these very often anymore because they can cause what's called barotrauma, which is lung trauma due to too much pressure. Um, and they're used to ventilate apneic or hyperventilating patients. Okay. So they can have what's called a demand valve, which is triggered by negative pressure generated by inhalation, right? So what does that mean, right? So if this is on the patient's face and the patient kind of sucks in a little bit, it'll trip a valve and the valve will say, oh, there's a demand for oxygen, and it'll shoot the tidal volume of like 500 into their face. Okay. Um, and so basically, the idea of this is the rescuer, if you're a single rescuer, you can use both hands to seal this on this face. And you're like, well, golly, Hunter, how hard is that? It's hard. Okay. To properly seal this on a face is the single hardest thing you will do in EMT school. I'm serious. This is very hard to do. And for a normal face like mine, shout out, it's not as hard as someone who's missing their jaw or has dental appliances or a big biker with a big beard, right? Like it becomes very difficult to make a seal on someone's big beard. Okay. So just be aware of that. And so, yeah, it's the manually triggered ventilation device. You don't see those a lot. So we actually have what's called, we have several different forms of these automatic transport ventilators. These can do a lot, right? You can set the rate, the respiratory rate, right? Also known as the frequency, F. Uh, the tidal volume, again, this is only around 500. The peak inspiratory time, so this can tell you like how long you want to deliver that breath. It's complicated. Um, and I'm actually not going to go much further into this because I don't want you to know a lot about this because EMTs don't use these very often. I just want you to be aware that there are machines that will do all of it for you. Okay? They're expensive. They're paramedic toys. And they're very complicated to operate and they can cause harm very quickly to patients if you don't know how to use them. Okay? So just be aware of that. And so the nice thing about a ventilator, I'll flip through these, is like an automatic ventilator like this one. This is a Zoll, right? Is you can fine tune a lot of things, right? How much pressure do you want to use? How fast do you want to deliver the breath? How long do you want, you know, what's the rate that you want to set? What's the PEEP, right? Or the CPAP, or like all these different settings you can set to clinically improve your patient. And where paramedics get in trouble is there's almost too many options. So, or they don't know what all the options do. So just be aware, right? Those are ventilators. Now, CPAP, really cool device. In Texas, I'm seeing a lot of EMS agencies allow straight up EMT basics to use CPAP. So we are going to talk about this. And I've talked about this quite a bit. So CPAP looks like this. And I'm going to link a video that I created several years ago for our staff on training on this device. Okay, and this is actually a BiPAP. But just know, just watch this video. It's like 10 minutes. It's very helpful. We actually pull one out. We put it on a guy, my good friend Don Fear, and we talk about it. We talk about the settings and how it works. And it's like 10 minutes, and it fully explains how this works. Okay, like this particular brand. Now, CPAP increases pressure in the lungs. And it opens up those collapsed grapes, right? The alveoli. And so we create our own type. And so this phenomenon is to increase positive and expiratory pressure. And the tool that does this is called CPAP, continuous positive airway pressure. And so the idea is if you increase the alveoli, right? And the surface area of these alveoli, and you increase the pulmonary compliance, like the compliance of the chest, then you will make ventilations easier for the patient. Okay. One thing I'll add about CPAP that I told you is remember those who have obstructive sleep apnea, those who snore or quit breathing in their sleep, they sleep with CPAP. So you will see patients that sleep with this. So it's indicated for patients with respiratory distress. As a general guideline, patients that get CPAP, as a generality, they need to be alert and able to follow commands. Okay. They need to be in pretty good respiratory distress. So this is kind of one of the big guns, okay, that we pull out in the more severe cases. So you could use this after a submersion incident. Why is that? If there's fluid in the lungs, let's just say if there's fluid in the lungs, it helps the fluid get absorbed, okay, in the blood. If there's rapid breathing more than 26 times a minute, right, it's good. And if the pulse oximetry is reading less than 90, it's great, right? So this is the big guns, right? This is a very, very powerful tool, CPAP, to use it. And I'm holding this mask just because this is the same mask used on our CPAP device. But it's this machine that I just showed you that I'm actually talking about. So what are the contraindications? When can you not use this? If the patient's unresponsive, if the patient's unable to speak or sit up or unable to protect their airway. So if the patient's unresponsive, you cannot use this. So if they tell you in the vignette, oh, they're unresponsive, you cannot use this. And I'm not going to test you on this heavily. I'll just tell you over some of these nitty-gritty details. I just want you to know what this is. If the patient's in respiratory arrest or has agonal respirations, you generally can't use, or you cannot use this at all, because this isn't like a ventilator where it's like large amount of volume, right? It's not doing that. It's continuous. It's just blowing air. It's not like a ventilator, right? So it's just continuous air. And then if they're hypoventilating or hypotensive, again, you can't use this. If there's a pneumothorax or chest trauma, closed head injury, facial trauma, right? Imagine someone with a busted up face. You're not going to be able to put this on their face or head. Or if they're in cardiogenic shock, again, you cannot use this. So I could explain to you why on all of these, but I don't think that's very important right now. Can't use this on someone with a tracheostomy. If you put this on their face, the air is going to escape from their tracheostomy. Or not get down to their tracheostomy if there's like an occlusion at their glottis. If there's active GI bleeding, nausea, or vomiting, why is that? It's because it could blow potentially a little air into the esophagus and the stomach and make that nausea, vomiting worse. Recent GI surgery procedure, again, you don't want to pump the stomach full of air if there's just an incision or surgery there. If you can't properly fit the CPAP, like say it's leaking over here by the bridge of their nose, that seems to be a favorite, or at their jaw, can't use it, okay? It has to completely seal on their face for this to work. Excessive facial hair or dysmorphic faces, right? If they have a messed up facial features, right? Really small jaw or something like a big old biker beard or something like that, right? You can't use this. Now, basically the phenomenon of this, let me just draw this out, good, right? So this is the patient, right? And this is their trachea. These are their lungs. So when they're breathing, so what's happening is this is forcing air in at a constant rate, right? And it's actually measured in like centimeters of water. So let's just say it's 10 centimeters of water, okay? And then what's happening is as the patient breathes out, right? They're breathing out a positive and expiratory. They're breathing out expiratory pressure. And so what that does is it keeps pressure in the lungs at the end of exhalation, right? So when they're breathing out, they are able to get their air out, but they're breathing against resistance, right? They're breathing against air coming in. So that creates PEEP, okay? And so what that extra pressure does is it keeps the balloons open, the alveoli open. And so we adjust this whole PEEP number somewhere between 5 and 20, right? 5 starting out, 20 is the highest end of that spectrum. And that's how we decide, our clinical intervention. And so really you kind of want to set this to what the patient can tolerate. Usually I find that mostly with 5 or 10 will do fine. And so of centimeters of water or PEEP. So this is like kind of how that's done. You got to be aware that if a patient's already anxious and having a hard time breathing, it's a hard sell to put this on someone's face and strap it to them. And like, it's very, they lose their, really for the most part, their ability to speak and communicate to you because it's muffled with all the oxygen and the mask. And so that's one thing. The other thing you have to worry about is uh, 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 like claustrophobia. And so what I like to do is ask the patient, do you sleep with a mask, right? And if they do, then they're used to CPAP. I'm like, great, I'm going to put one of those on you, okay? And so they already know, right? And I've actually had patients come in, they're like, I need CPAP, right? And they already know they're about to get the mask. So um, it is possible to cause a pneumothorax. Remember, a pneumothorax is a hole in the lung or a blown lung as a result of baro trauma. Remember, baro means pressure, so that says like pressure trauma to the lung. Okay, increased pressure in the chest cavity can result in hypotension. Why is that? Remember, as the lungs hyperinflate, they can squeeze on the inferior vena cava, which is the big vein that runs to the right side of our center right of our chest. And when you squeeze on that and create a little form of obstructive shock, which decreases preload to the right side of the heart, which will cause low blood pressure. Okay, can cause gastric distension. I've talked about this. Probably not going to say much more about that, but just be aware when we pump air in the stomach with BVM, CPAP, however you did it, it is going to come out. Okay, and it's probably going to come with some tacos and beers as well. They're going to regurgitate. They're going to vomit. So yeah, the laryngectomy, tracheostomy, stoma, tracheostomy tubes. Um, A laryngectomy is when they remove the vocal cords. Okay, that's pretty rare, but that can happen, especially if they have like cancer of that area. Now, um, because of that, they have to put a tracheostomy tube, which is the tube down here, and then so basically with that, you what. So think about this: if you remove the nose, which is filtering, warming, and humidifying oxygen, and trapping bacteria, and grabbing out that dust, if you remove that then you can end up with like some pretty severe mucus development down here and infection and dirt and all these issues. So just be aware that you have to be careful, and that can create, you can get a mucus plug down here suctioning the stoma or the tracheostomy. A stoma is further down, it's like down here. And so or a stoma is like just an opening of the hole, and the tracheostomy tube is like the tube that can go into a tracheostomy. Confusing. They're not going to ask you to the specifics of the differences of those. Just know stoma, tracheostomy, pretty much the same thing. It's a hole down here in the lower neck, lower throat. So you can use mouth to stoma, okay? But you can, just like mouth to mouth, do mouth to stoma. Now, test question. Your patient has a stoma. Do we do mouth to mouth? No, it is mouth to stoma. This could be shut off, right? If they've had a laryngectomy, or we don't know what's the pathology up here. Is it completely shut off, right? I don't know. And so you would have to use mouth to stoma or a mouth tracheostomy tube or something like that. Now, let me tell you this. If this tube pops out, it's a medical emergency. Hopefully the family or you can get it, put it back in. And I think it may even be a paramedic skill to put that back in. But usually the family will put it back in. So just be aware. But what I've had happen, I've had this happen before. They got the tube popped out and they couldn't get it back in. So we had to put an endotracheal tube, a smaller size tube, into that hole for them and take them to the hospital. Don't care. Dental appliances, what are those, right? These are like dentures and, bridges and all those things in people's mouth. So these should be manually removed if they're loose. If they're glued in, you don't really have to remove them. But one thing I'll add is be careful. These are very, very expensive and they're custom to the patient. I actually got wrongly accused once of misplacing or stealing uh, these from a patient who projectile vomited at a hospital near us. And the hospital blamed me specifically, even though in my report I literally wrote Upon entry to the ER, the patient projectile vomited, her denture shot out into her lap. I washed the dentures in the sink, placed them on a clean towel next to the sink, and notified the receiving nurse and physician of the location of the dentures. I documented that, and they still blame me. So my boss looked at my chart and said, we have it documented they were right here. Y'all must have thrown them away or put them in the laundry basket or whatever. And so we were cleared of wrongdoing. But they were threatening to, the hospital was threatening to sue us and the family for these $6,000 dentures. And so, yeah, that's a case of documentation saving me. That's probably my best scenario of documentation saving me. So just be aware these are expensive and these are very important to a patient. So don't lose them. Don't just chunk them, right? Give them back to a family member or make sure that they're safeguarded and you're documenting what you're doing with them if you remove them. Now, facial bleeding. This can the face bleeds a lot. It's very vascular by design. God made us that way. So just be aware that we obviously don't put a tourniquet on the face. Excuse me. So we have to apply direct pressure and or suction to clear out the blood. Anytime you have a facial injury, right, like a baseball to the face or something like that, or someone who's punched really hard in the face, you need to suspect cervical spine injury, right? The cervical spine is the top part of the spine, the neck. And remember, what device do we not put into patients with facial trauma or head trauma? NPAs. They can't have them, okay? Why is that? You can push this through the cribriform plate right into the brain. Foreign body airway obstruction, been there, done that. So just be aware that first, kids put things in their mouth. Second, old demented patients tend to behave like kids and they will put things in their mouth that they're not supposed to. I told y'all the story of the lady eating grapes. The more tragic part of this story is her husband, they were both demented, had a caregiver. Her husband went and got grapes for her and put like 10 grapes in her mouth. And one of them, or two of them, I don't know, obviously got stuck into her trachea and she died. And so we're trying to clear all these half mashed grapes out of her mouth and trachea. It was a really bad call. Almost ended up cutting her airway to do a surgical airway. So just be aware, okay? Now, what's the universal sign of choking, right? This. Now, with a mild airway obstruction, the patient can cough, so watch for that in exams. If the patient can cough, they should cough, right? That could clear the obstruction. If the patient is not coughing or speaking, it is a complete obstruction. They're going to go into cardiac arrest if it's not cleared. So you would do the Heimlich. If they go unconscious, you do CPR, okay? Now, very important line here. I don't care what you saw in 2002 from a first aid course, right? This is what I'm telling you the answer is. Attempts to remove the object manually could force the object further down into the airway and cause a severe obstruction. So we don't do blind finger sweeps anymore. We don't just start trying to sweep like this through their mouth to get the stuff out. You might push it further, right? Rule number one, do no harm. So we don't do that, okay? So if the patient is found unresponsive and if it does not appear to be breathing, we're going to begin CPR. Full-blown CPR. What, Hunter? What if they have a pulse? If they're not breathing and it's from an airway obstruction, we start CPR. Now, this last part, I'm going to buzz through it because this is like more so assisting paramedics. And if you want to end the video now, you can, but it's going to take like 3 minutes. But these are devices that in Texas, you can put in. But in the National Registry, you cannot as an EMT basic. So the first one is a King Airway. And basically, this is a shove push procedure. And we'll have these out in the lab, by the way. We'll have all these different examples of these tubes. And you'll get to put these into a mannequin so you at least know how they work. But what you do is you open up the patient's mouth and you shove this into their mouth until it sits, until it goes all the way in. You inflate this balloon right here with a big syringe, and you attach the BVM right here. Oh, or my pen went. Right here. Oh, it's up here. Right here. Okay, you attach the BVM, the back valve mask. And how do you do that? You remove the mask, and this adapter right here will perfectly fit this adapter right here. Okay? They'll accept each other and make a bond. This is what they do, right? So you shove this into the patient's mouth, and hopefully it'll go into the epiglottis, and then there's a little opening right here, so when you breathe, air will go in here into the trachea. That's how that works. And when you're like, well, that's kind of cool. What's cool about that is it seals off the esophagus. So if they vomit, hopefully, and if it's put in properly, the vomit will be sealed off by that balloon. Okay, I'm just going to show you. So this is what's called a laryngeal mask airway, or an LMA. And so it looks like this. Looks like this. Okay, and same concept. You just shove it into the patient's mouth. It's a shove, shove, push procedure. And so you just shove it in the patient's mouth. And again, hopefully it sits in the esophagus. There's not a balloon as much on this one. Some of them do. Well, this one does have a balloon, but it's not as sealing per se. And this is used a lot in surgery, by the way, and so like elective surgeries. And so basically it's the same concept as a King Airway. It's just a different brand. Okay, we're almost done. iGel, this is what the Park County Hospital District's using right now. These are pretty good devices. These don't inflate, but they're different sizes. And so basically, again, it's a shove, shove, push procedure. You shove it in there. Hopefully it goes down the esophagus. You attach your BVM here, and it'll push air down into the airway, the trachea. Okay. Cobra, never use this. It's an LMA with a little inflatable balloon. Don't care. Combi tube, one of the worst things ever created. And so basically, it's the same thing. It's a shove, shove, push procedure. You shove this in the patient's mouth, and you put the BVM here first, and you listen over the stomach. And if you listen over the stomach, that's the esophagus tube. Don't use that one. And then you put so you don't want to ventilate that. So then what you do is you put the BVM here and you listen to the stomach. No stomach sounds, now you listen to the lungs. Hear lung sounds, you're in the right place. Use that tube. So a combi, as in like more than one, there's literally 2 tubes attached to this. And so it's this, these are very archaic. I haven't seen these in a long time. I've never used these on a real patient. I've only seen these in like classrooms. Okay. Now, this last part, assisting with BLS or assisting with intubation. I don't have an endotracheal tube here with me. I wish I did. But it's a tube, obviously, that goes through the mouth. And this is a paramedic skill or an advanced EMT skill in Texas, but a paramedic skill that will go into the mouth and into the trachea. And so it's just one tube, and the idea is you don't place this one in the esophagus. You place it directly into the trachea. You inflate the little balloon at the end, and it seals off the trachea. So if they do vomit, the vomit's going to be in their mouth, but it's not going to go into their airway, into their trachea. So it's easier for me just to show you, or for us to show you in class what this is and how it's done. And the value of this is being able to assist in it, because your paramedic partner is going to have his hands very busy. And if you know how to help with this and like what his next steps will be, then it makes you very, very, very useful. Okay, so it's not complicated. It's just not an easy procedure that I don't think is respected by EMS professionals anymore. There's a lot to it, and what's hard about it is you stick, again, we'll show you in class, this tool in someone's mouth, and you have to like lift up their jaw and tongue, and then look in their mouth, right? And then you have to like take the tube and like position it perfectly in their little bitty trachea through their vocal cords into their trachea, right? So it's like all these steps and stuff, and it's not hard per se, it's just commonly messed up. One of the reasons is because we don't do it terribly often. Maybe a couple times a month on most systems, most services, but as a paramedic. But anyways, we'll talk about this in class. I could explain this to you here, but if I just show you one time how we do this, on a mannequin, you'll be like, oh, okay, that's endotracheal intubation. That makes sense. So it's good stuff. I'm a big fan of intubation. So anyways, that's it for this video. We're done with chapter 11. Again, guys, airway management, there's a lot to this. This is just scratching the very tippy tip of the surface. And I think this will come together a lot more in class when we have mannequins and I'm showing you how to do a jaw thrust, and we'll be grilling you. When do you not do this? When do you do that, right? And you're going to be able to spit out these answers. So when you do get asked this on a test, you'll be like, oh, no, we don't do that. We don't use a jaw thrust, or we don't use a head tilt chin lift in these scenarios. We would use this, and we do this, and we don't do that. And those kind of intricacies, I think, come together in the lab and like face-to-face when we're hands-on. And I think that can carry over into our exams. So with that, I appreciate y'all's time, and have a good day.